Well, I think we can go ahead and get started. I congratulate this. The crowd arrived early for our speaker, so that's good. Our speaker today is somebody who will really give us a lot of information about the consequences and the risk factors of sudden death and how to treat them with AICDs, and look forward to his talk. The speaker is Basil Merchant. Dr. Merchant is assistant professor here at Emory in cardiology. He was born in London, grew up here in Atlanta, and then went to Duke to do his residency and do his fellowship training there. He had gone to college here at Emory and then went on to Duke from there. And he spent time, he's well written. He's talked about and written about ICDs and the questions such as when do you stop them? Do you ever replace one? Do you not replace it? And these are things that he'll probably touch on today. As I look back at his thing, I realized that he and I have three traits in common. We're both Duke basketball fans. Secondly, we're also frustrated golfers. And the third one is we both enjoy reading political biographies. And so I look forward to your talk. And I've heard part of this previously, and it's well done. And appreciate you being here with us today.
So thanks for the invitation to speak today. As you can see from the title, I'm going to be talking about atrial fibrillation and whether we should be screening for atrial fibrillation or not. And although I posed the title as a question, the truth is that screening for atrial fibrillation is going on all the time. There's been a massive proliferation of Apple Watches and Fitbits and things like that that are capable of screening for arrhythmias. And so patients are going to be increasingly coming to us saying, hey, my watch detected X, Y, or Z, and we're going to have to figure out what to do with that information. And so we're going to spend the next 45 minutes or so talking about that. But just before we get started, out of curiosity, how many people in this room have an Apple Watch, a Fitbit, a Kardia band, some device that is rhythm monitoring enabled? So it's probably about 50% or so. And this is obviously a younger, probably more tech savvy crowd than some, but a lot of people have these kinds of devices, and we're already starting to see more and more folks walk into our clinics with things that are detected by these devices. So we're going to talk a little bit about that. We're going to break the talk down into four big components. We'll talk about the options for screening for atrial fibrillation. We'll talk about the kinds of patient populations that you might think about screening. We'll spend the bulk of the time talking about treatment, because at the end of the day, the question is, what do we do with this information? And then we'll finish up talking about some of the pitfalls of screening and why I'm hesitant about whether this type of technology is really going to improve patient outcomes. But we'll finish up with that. So I just want to start out with some definitions. Everything that we talk about from here on out is going to fall into the category of subclinical atrial fibrillation. Now, this is sort of an arbitrary distinction between subclinical AFib and clinical AFib. But most of the time in the literature, subclinical AFib is defined as relatively short, asymptomatic episodes of atrial fibrillation that are typically detected by some kind of continuous rhythm monitoring, a watch, a Holter monitor, an event monitor, telemetry in the hospital. What we're not talking about is clinical atrial fibrillation, which is either defined as that which causes symptoms or that which is picked up on a 12-lead EKG. Now, certainly you could make the argument that just because you in happenstance pick up AFib on a 12-lead EKG in the office, is it really any different than AFib that's picked up from a watch? And the truth is, it does seem like a somewhat arbitrary distinction, but at least the current literature really seems to make this distinction. So everything that we're going to talk about is subclinical AFib and the kind that it does not cause any symptoms. Now, this will come as no surprise to anybody in the room, but I do want to talk about the rationale for screening. Obviously, atrial fibrillation is very common. If you look for it, you're going to find it. The prevalence of AFib is less than 1%, people less than the age of 50. But as you get into your 70s and 80s, the prevalence of AFib is over 10%, just as a function of age. So if you screen older individuals with comorbidities, you're going to find atrial fibrillation. AFib is obviously a major cause of ischemic strokes, probably accounts for about a quarter of all ischemic strokes. And if you look at these two panels over here, strokes due to AFib here in the purple bar cause much greater neurologic impairment even a year out from the stroke compared to strokes due to non-AFib mechanisms. So not only does AFib cause a lot of strokes, but it tends to cause pretty bad strokes. Anticoagulation is obviously effective at preventing strokes due to atrial fibrillation. So it makes sense that if you can screen somebody, particularly people who are at risk for AFib and strokes, identify the AFib early, initiate anticoagulation, maybe we can prevent the morbidity and mortality associated with those strokes. So that's the rationale, and it makes pretty good sense. Unfortunately, and somewhat cynically, I think a lot of what is happening with screening these days has less to do with preventing strokes and morbidity and mortality, and more just that a lot of devices are capable of screening, and it makes for good direct-to-consumer advertising, the sort of, manage your own health, be an active, engaged healthcare consumer. And so I think that's what drives a lot of the current screening. And we'll talk about how the paradigm of preventing strokes may break down once you start screening relatively younger, healthier patients, or relatively younger, healthier people, not even patients, with these kinds of Apple Watch and Fitbit devices. So the whole paradigm for screening actually really came on the heels of the ASSERT trial. I want to spend a couple minutes talking about ASSERT. ASSERT was published in the New England Journal in 2012, and it was a cohort of about 2,500 patients who did not have any known history of atrial fibrillation, all of whom were undergoing either pacemaker or defibrillator implantation. So already, and they were all over the age of 65. So already you're talking about an older age group who have comorbidities that resulted in them needing either a pacemaker or a defibrillator. The ASSERT investigators defined subclinical AFib as any episode of AFib that was detected by the pacemaker or defibrillator that lasted more than 6 minutes. And if you follow this cohort of 2,500 patients who had no known prior history of AFib forward, about 10% of them had an episode of AFib detected by the device lasting at least 6 minutes within 3 months. And if you follow out to 2.5 years, about a third of individuals had an episode of AFib meeting that 6-minute definition. So it's obviously very common. And for people who had subclinical atrial fibrillation, they had about a 2.5-fold increase in their risk of having a stroke or systemic embolism compared to those who did not have any subclinical atrial fibrillation. So ASSERT really put some data behind the idea that if you can screen individuals, identify these subclinical episodes of AFib, then there may be a way to prevent that increased risk of stroke. Now, obviously, ASSERT used pacemakers and defibrillators, which are an invasive screening modality. Well, there's a whole host of ways that you can screen for atrial fibrillation. There are invasive methods, pacemakers, defibrillators. Many of you may be familiar with the kinds of implantable loop monitors that are embedded beneath the skin. There are non-invasive options, Holter monitors, event monitors, watches, things like that. There are also different technologies that can be used for screening, and we'll spend a little bit of time talking about this, but most devices that screen for atrial fibrillation use one of two technologies. They're either ECG-based or they're pulse-based. And actually, a lot of the watch technology is pulse-based, and we'll talk about that. And then you can either screen continuously, for instance, with a pacemaker, which is in there all the time, or intermittently just screen for the hours that you happen to be wearing your watch. Or there's opportunistic screening. You can screen people with an EKG every time they come into the office. So obviously, the sensitivity and specificity are going to vary depending on whether it's a continuous screening modality, an intermittent screening modality, whether it's invasive, non-invasive, things like that. So a lot of different options for screening. I'm not going to get too into this data, but there have been a large number of studies over the last couple of decades looking at the sensitivity and specificity of various screening modalities for identifying subclinical atrial fibrillation. And a lot of the sensitivity and specificity obviously depends on what you use as a gold standard. But without getting too into the details of these studies, across the board, a lot of these studies show sensitivities and specificities in the 90+% range, which would suggest that these screening modalities are actually pretty good. If you have subclinical atrial fibrillation, these devices will find them. And so it makes sense that if you have sensitivity and specificity in the 90+% range, that maybe we ought to be able to effectively screen individuals for subclinical atrial fibrillation. When we come back to some of the pitfalls associated with screening, we're going to come back to this sensitivity and specificity issue at the end of the talk. But suffice it to say, at least as a first pass, it does look like the sensitivity and specificity of most of these modalities is pretty good. I want to spend a little bit of time talking about this distinction between ECG-based screening and pulse-based screening. So ECG-based screening is pretty intuitive, right? It's some rough approximation of the kind of EKG that you would do in the office or in the hospital. If you wear a Holter monitor that's got a couple of electrodes on it, that's basically ECG-based screening. With a pacemaker or defibrillator or something like that, the atrial lead's not truly an ECG, but it's actually recording electrical activity in the heart. So those are all methods for screening for AFib that directly measure electrical activity in the heart. The alternative to doing that is to try to screen with some sort of pulse-based technology. And the major technology that's used for screening is something called PPG or Photoplethysmography. And this is the way that the Apple Watch, at least Apple Watch generations 1, 2, and 3, screen for atrial fibrillation. So this is a slide taken directly from the Apple website. And their website actually does a pretty good job of explaining the technology behind their hardware. But if you flip an Apple Watch over on the back, you see something like this. There's a little round black disc on the back. And there are 4 green light emitting diodes on the back. And in the middle, there's 1 infrared light emitting diode. And the way that the Apple Watch uses PPG to screen for atrial fibrillation is that every time there's a pulse, there's a change in the volume of the microvasculature. And the microvasculature volume changes impact the absorption of red and green light. And so the ratio of red and green light absorption changes as a function of the pulse. And that's basically the way that Apple detects atrial fibrillation using their PPG-based sensor. And they say that their watch technology will support detection of heart rate over a dynamic range from about 30 up to 210 based on the ratio of red to green light absorption. So this is sort of what PPG-based technology looks like. You can see you have this waveform here, and you can measure not only the amplitude of the waveform, but also the pulse interval or the RR interval. And the PPG plot looks something like a pulse oximetry waveform. And so in essence, PPG is very similar to pulse oximetry. If you're in sinus rhythm, you have a nice stable PPG waveform where not only the amplitude, but also the pulse interval is regular from beat to beat. And that's what sinus rhythm looks like. In contrast, atrial fibrillation down here, you can see that the amplitude on a beat-to-beat basis changes as a function of the preceding diastolic interval, and also the actual pulse interval changes. And that irregularity in the waveform, the PPG waveform, is what's used to detect atrial fibrillation. Now, right off the bat, you can imagine that if you had a lot of PACs or a lot of PVCs, you could get quite a bit of irregularity in the PPG waveform and have a false positive detection for atrial fibrillation. And the opposite's also true. There are a lot of people who go into atrial fibrillation, but if your heart rate's relatively well controlled and you've got AFib in the 70s or 80s, the pulse interval and the amplitude might actually be quite regular, even though you're in AFib. So PPG is certainly not perfect, and there's the potential for both false positives and false negatives. But this is the way that Apple originally designed generations 1, 2, and 3 of the Apple Watch. If you look at data around PPG, this is one study of about 600 patients who were hospitalized, and they screened them using a watch that was PPG enabled and simultaneously obtained an EKG using a smartphone. Something that's important to note, about 20% of the PPG recordings in this cohort were uninterpretable, either because the contact with the wrist wasn't very good or other reasons for the data not being usable. So with any of these devices, there tends to be a fairly high rate of uninterpretable data, and we'll come back to that. But if you look at the 80% or so of the data segments that were interpretable, sensitivity is about 94% for the detection of atrial fibrillation, specificity of 98.2%. So again, the PPG, if you can interpret the data, seems to work quite well. Now, PPG, like we said, was how Apple designed generations 1, 2, and 3 of the Apple Watch. About 2 years ago, when Apple Watch version 4 came out, and now subsequently version 5, there was a lot of fanfare and a big press conference in conjunction with the AHA around the ability of the Apple Watch 4 and 5 to actually obtain an EKG. So moving from pulse-based detection of AFib to EKG-based detection. And what Apple did with generations 4 and 5 is add this sensor on the side of the watch. So for any of you who have versions 4 or 5 of the Apple Watch, you'll see that there's a sensor on the side. And in effect, if you're wearing the Apple Watch on your wrist and you embed an ECG electrode on the back of the watch, and then you touch that button with your opposite hand, in effect, and you've embedded an ECG sensor in that button, in effect, now what you've done is create an ECG lead going from the right arm to the left arm, and it generates something that looks very much like ECG lead 1. If you wear the watch on the right wrist and touch that button with your left arm, you basically get the same vector in the opposite direction. And so this is the way that versions 4 and 5 obtain a single lead ECG that looks very much like ECG lead 1, right arm, left arm. So the way that versions 4 and 5 work is the PPG function is running in the background all the time when you wear a watch, when you wear an Apple Watch. If the PPG sensor starts to detect irregularity concerning for atrial fibrillation, it does two things. It increases the sampling frequency of the PPG algorithm, and it also prompts the wearer to obtain an EKG. And you can obtain a 30-second EKG snippet and save that, and then bring it in to your doctor or send it in electronically or whatever the case may be, saying, hey, this is what my watch has detected. So that's the way that the technology works for the Apple Watch. Fitbit is similar, in Garmin. There's a number of other devices, all of which have variations on this theme of either ECG or pulse-based detection. The other devices that we see pretty frequently in the clinic that a lot of people own are these Kardia devices. And so I want to spend a second talking about Kardia. The original Kardia Mobile is this strip that you can attach on the back of your phone or keep it in your pocket or whatever the case may be. But the strip has two metal electrodes on it, and it works very much the same way. If you put one thumb from one hand on the strip and the thumb from the other hand on the strip, in essence, again, you've generated ECG lead 1, and you can obtain an EKG from the right arm and left arm. What Kardia has recently come out with is something called the Kardia Mobile 6L, which allows you to generate all 6 of the precordial leads from that same strip. And the way they've done that is retain these same metal plates on the front, but there's a third metal plate on the back. So if you hold the strip with your thumbs on top and then touch that strip on the back to your left leg, either at the ankle or the knee or some exposed skin on the left leg, you can now generate all of the ECG leads from right arm, and left leg, which allows you to generate all 6 of the all 6 of the limb leads. So we're moving from single lead screening to 6 lead screening, which is, it's really a pretty nifty idea. We see people come into the clinic with these devices all the time, and they tend to give you a pretty high fidelity recording. And it's nice to be able to get multiple leads if it's a little bit unclear of what's going on in one lead. Obviously, this is a little bit more involved than just wearing the watch all the time, but it probably does give you a little bit better data. So obviously, this will come as no surprise to anybody, but a lot of people have these devices. The market for wearable connected technology is enormous, and it's estimated that about 1 billion people worldwide will have ECG-enabled or rhythm monitoring-enabled devices within the next year or two. We've got Christmas coming up. I'm sure there are a lot of requests for Apple Watches or Fitbits or things like that. So there's a lot of people walking around who don't have any symptoms who have these devices. And the question is, what do we do with that? Before we get into the treatment, I do want to talk a little bit about the kinds of populations that you might think about screening for atrial fibrillation. So if we are going to use one of these devices to screen for subclinical AFib, who could you potentially think about screening? I think there's probably 3 big categories of people that we think about screening for AFib. There are those who have had a embolic stroke of unknown source, or what used to be called a cryptogenic stroke. There's often a lot of concern for occult atrial fibrillation. I think screening probably makes some sense. You could think about screening people who are at high risk for developing AFib but aren't yet known to have it. Or you could talk about screening the entire population. Anybody who's running around with one of these devices could potentially be screened. And I want to talk a little bit about the data for screening in each of these 3 patient populations. The people who have had embolic strokes of unknown source or cryptogenic strokes, frequently there's concern for occult atrial fibrillation. So we see somebody come in with a stroke that looks like it's of embolic origin. You do whatever workup in the hospital, TEE, whatever telemetry monitoring. Often we send those folks home with some kind of 30-day event monitor to look to see if they're having occult atrial fibrillation. And if they don't, one of the things that we frequently will do is put in one of these implantable link monitors, which is capable of monitoring for 2, 3, 4 years. And these take just a few minutes to put in. And they provide basically a single lead EKG just from beneath the skin. The Crystal AF was a study that took about 400 individuals who had had embolic strokes of unknown source and randomized them to either monitoring with a 30-day non-invasive monitor or monitoring for occult atrial fibrillation with one of these implantable devices. Now, one of the things that's important is Crystal AF, rather than using the 6-minute duration cutoff from ASSERT, used a duration of 30 seconds for subclinical AFib. Here you can see the Kaplan-Meier figures. If you take a bunch of people who have had a cryptogenic stroke and implant them with these devices, about a third of individuals are going to have episodes of subclinical AFib over the next couple of years or so. And that 1/3 number is actually pretty similar to the 1/3 that was seen in ASSERT. And the presumption here is that if these people have already had a cryptogenic stroke, you've now seen subclinical episodes of atrial fibrillation, that anticoagulation would be prudent to prevent a second stroke. So if you look for AFib in this population, we find it pretty frequently. Now, you could argue that if the prevalence of atrial fibrillation at a year or two after a cryptogenic stroke is over 30%, then does it make sense to even screen? Why not just put everybody who's had an embolic stroke of unknown source on empiric anticoagulation, with the idea that the background prevalence of AFib is sufficiently high that if you look for it, you're going to find it and end up anticoagulating them anyway? There were actually 2 studies that did exactly that, both of which were published in the New England Journal within the past year or so. Navigate ESUS there on the left used rivaroxaban. Respect ESUS on the right used dabigatran. But basically, they were very similar studies. They took individuals with embolic strokes of unknown source and randomized them right off the bat, no screening, no implantable loop monitor, to anticoagulation or not. And interestingly enough, both trials were negative. At least over the duration of follow-up, there was no significant difference in the risk of recurrent stroke. And not surprisingly, the incidence of bleeding was higher in the arms that were randomized to anticoagulation as opposed to the control arms. So it doesn't seem like empiric anticoagulation in this population is necessarily going to be the right answer. We're going to have to figure out some way to enrich for those individuals who are most likely to benefit from anticoagulation and who are most likely to have atrial fibrillation as a cause of their embolic event. So I think it's still very unclear what the optimal way is to screen people who have had a cryptogenic stroke. But empiric anticoagulation, based on these 2 studies, doesn't seem like it's going to be the ideal approach. What about screening people who have not had a stroke, but who are at relatively higher risk for having subclinical atrial fibrillation? As we said already, once people get into their 60s, 70s, 80s, the background prevalence of AFib approaches 10%. And a lot of those individuals have higher CHADS2 VAS scores just as a function of age and comorbidity. And so it might make sense to look for subclinical atrial fibrillation in people who are at risk but aren't known to have it. REVEAL AF is a study that did exactly that. It took 385 individuals. All of them had worn prior Holter monitors or event monitors and had not been documented to have any atrial fibrillation, and implanted them all with those same implantable loop monitors. Now, this was a relatively higher risk cohort. They didn't have any known AFib, but the mean age was in the 70s, and the CHADS2 scores were all 2 or greater. And they used the 6-minute definition for atrial fibrillation. And if you follow people who aren't known to have any atrial fibrillation, just the kinds of folks in our clinics who are in their 70s, who have high blood pressure and diabetes and that kind of thing, and if you look hard enough, about 40% of individuals over the next couple of years will be found to have subclinical episodes of atrial fibrillation. So it's a very high prevalence if you look hard enough. Now, the question is, are these episodes of sufficiently increased risk to justify anticoagulation? And we'll come back to that. But if you just take individuals in their 60s and 70s, whether they've had a stroke or not, whether they have pacemakers or defibrillators or not, or whether they just have other risk factors, hypertension, diabetes, that kind of thing, about a third of these individuals in ASSERT, in Crystal, in REVEAL, that number is always right around a third, will be found to have subclinical AFib at about 2.5 years. And that finding has been pretty consistent across a number of studies. So what about screening people who are not at particularly high risk? Does it make any sense to screen people who are young and healthy and don't have any symptoms? And that's where I think this really gets to be much more murky. I want to spend a few minutes talking about the Apple Heart study. Apple Heart got a lot of coverage in the lay press. It was in the New York Times. It's been all over the news. These slides, the next few slides, are from the presentation at ACC earlier this year, but the paper was just published in the New England Journal, and the data and the slides are basically the same. But what the Apple Heart study did was took anybody that had an iPhone 5S or later and had an Apple Watch Series 1, 2, or 3. So the Apple Heart study only used the PPG-enabled technology. It didn't use the single lead EKG. So this is all PPG-based technology. But anybody that had an Apple phone and an early generation Apple Watch that wanted to sign up online could sign up to participate in the study. And anybody who had a known history of AFib was excluded. But in essence, the way the study worked is that once you bought your watch and you had your phone, you signed up online, and then you just went about your business. If the watch detected an alert that was concerning for AFib, you were connected online to a telehealth physician who did some kind of assessment to see if you had any concerning symptoms. If you did, you got sent to an emergency room or whatever medical triage was necessary. But if there weren't any concerning symptoms, the study then mailed a 14-day, basically a Holter monitor, a 14-day electrode patch as a confirmatory measure. And then you were again connected to the telehealth doctor to review the results of the patch, and you exited from the study. So the study ran for about 7 or 8 months or so. That was the period in which you could get online and sign up. During that period, 420,000 individuals, I shouldn't say patients, 420,000 individuals signed up to be a part of the study. So I don't know how much the Apple Heart study tells us about whether or not we should be screening for AFib, but I think it does provide a paradigm for this sort of wearable, connected, virtual clinical trial platform, which I think we're going to start to see much more of, because it does allow you to enroll a large number of individuals in a very short amount of time. Out of that 419 or so thousand, 99.5% went through that entire 6 or 7 month period without receiving any abnormal alerts. There were only about 2,000 alerts, and only about half of those people that got an alert bothered to do the telehealth visit. From the group that had the telehealth and got the patch mailed to them, only 600 and something actually wore the patch. And then about 450 returned the patch. So out of 420,000 individuals that signed up, there's usable data on about 420. So the actual output in terms of data was somewhat limited. But if you look at the kinds of individuals that signed up, not surprisingly, these are all people who have a relatively modern iPhone. They've got an Apple Watch. They're savvy enough to want to sign up for an online study. So these generally tended to be younger, healthier individuals. Mean age was in the low 40s or so. And the prevalence of risk factors was relatively low. So this is a pretty healthy population. In contrast, of the 0.5% or so that got alerts, they tended to be older and had a higher prevalence of comorbidities, which kind of makes sense. The people who are likely to get alerts for AFib are going to be older and they're going to have more comorbidities. So at least that part seems internally consistent. The prevalence of alerts for people over the age of 65 that participated in the study was about 3%, whereas for people who were younger, the prevalence of alerts was in the 0.2, 0.3% range. So the fact that age does seem to predict the likelihood of getting an alert sort of fits with what we know about atrial fibrillation, right? The likelihood is going to be higher in older individuals. The positive and negative predictive value, at least that was reported in the paper for the Apple Watch, the positive predictive value was only 0.84. So it's not bad, but certainly not perfect. Now, one of the problems with understanding the positive predictive value from this study is that, remember, these people are out and about wearing their watches. And if you get an alert on the watch and then somebody mails you a patch a week or two later and you happen to wear the patch for 14 days, because AFib is inherently paroxysmal, it's entirely possible that you might have actually had AFib while you were wearing the watch. But by the time you got the patch and for the 14 days you were wearing the patch, there was no AFib detected. And that would have actually counted as a false positive against the watch. But there's really no way to know whether that watch recording was a true positive or a false positive because there wasn't any confirmatory testing at the time that the alert came in. So a lot of the alerts that were included in this study, it's very hard to adjudicate them as being true positives or false positives. There were a small number of individuals who had simultaneous alerts while they were wearing the 14-day patch. And that's where I think the best data probably comes from, because that gives you an opportunity to see whether the watch alert was confirmed from the patch. And if you look at that relatively small number, the sensitivity was only 40%, 47%, meaning half the people who had AFib detected from their patch did not have it detected by the watch. So obviously that's concerning if you're going to use this as a screening modality. The specificity was 95%. So if the watch detected AFib, there was a pretty high likelihood that that's what was identified based from the patch. But the sensitivity, at least in this study for the watch, and remember, this is only the PPG enabled technology, not the ECG, was not very good. So whether the Apple Heart study tells us anything about the utility of screening low risk populations or not, I think remains very unclear. But it does demonstrate the feasibility of being able to enroll a lot of people in a study in a short amount of time, even if the quality of the data is not so great. There's one other study that's actually done a similar thing. It's a much smaller study where they had people wear watches that were enabled with an ECG screening electrode, not just the PPG, and simultaneously implanted all of them with link monitors for confirmation. This was a much higher risk cohort of individuals. The mean age was in the 70s. A lot of them had cardiovascular comorbidities. Here, you saw almost the opposite. The sensitivity of the watch was actually quite good, but the specificity wasn't as good, so the positive predictive value was low. So I think not surprisingly, the diagnostic performance of these tools is going to vary based on the background population that's being screened. And how effective this screening turns out to be, I think remains very unclear. Just for the sake of completeness, I do want to mention the HUAWEI study. It's one other large study of about 200,000 people done in China, all of whom had PPG-enabled HUAWEI phones, which I'm sure you've heard of HUAWEI a lot. It's in the news. But they did the same kind of thing, enrolled over 6 or 7 months or so, and and did the same thing where they mailed people confirmatory patches and showed a positive predictive value of about 91, 92% for the HUAWEI-enabled smartphones. So again, these are relatively young, healthy people in China that have smartphones that are being screened for atrial fibrillation. I think over time, we're going to learn much more about the sensitivity and specificity of these devices in low-risk populations. But suffice it to say, when you really drill down and try to confirm whether these recordings, whether they're PPG or ECG enabled, are actually AFib or not, the devices don't always perform as well as we'd like. So that's sort of the data on how these devices perform. We're going to spend the next few minutes talking about what to do with this information. So how do you treat somebody with subclinical atrial fibrillation? And this is obviously the biggest question, right? It doesn't make any sense to screen somebody if you're not going to do something with that information. Now, a lot of people argue that, well, screening makes sense if for no other reason, because you can use it to motivate risk factor modification. And I think that's probably true to a certain extent, right? If people have risk factors for AFib, if they're overweight, if there's concern for sleep apnea, poorly controlled blood pressure or diabetes, and you identify subclinical AFib, it might make sense to aggressively modify those risk factors to prevent progression to clinical AFib. Whether or not it's worth screening those people, running the risks of false positives and inappropriate treatment with anticoagulation simply to motivate risk factor modifications, unclear to me. I mean, you could argue that if risk factors are present, we ought to work on modifying them, even if you haven't identified subclinical atrial fibrillation. So I think the argument of screening strictly to spur risk factor modification, in my mind, is probably not all that strong. Where the rubber meets the road is really whether or not you should anticoagulate somebody for episodes of subclinical AFib. And that, I think, is the really hard question. If we go back to the original ASSERT study, the one that really sort of set the stage for the screening concept, remember, ASSERT used a 6-minute duration as the threshold for calling an episode subclinical AFib. And the risk of stroke went up by about 2.5-fold in those who had a episode of subclinical AFib meeting the 6-minute definition. The ASSERT investigators actually went back a couple of years ago and looked in more detail at those episodes of subclinical AFib and identified something that I think is actually pretty useful. If you look here in the larger figure, the incidence of stroke or systemic embolism in the yellow line here really only increases significantly in individuals who had episodes of subclinical AFib that lasted more than 24 hours. For individuals that had episodes that were either 6 minutes to 6 hours, 6 hours to 24 hours, there was not any increased risk of stroke or systemic embolism compared to those who did not have any subclinical AFib. So most of the increased risk seems to come from people who have episodes of more than 24 hours. I will tell you that this is for us in EP a day in and day out issue. We have thousands of individuals in our device clinics with pacemakers and defibrillators, and we get alerts routinely saying so-and-so has had an episode of AFib lasting 3 hours or 2 hours. They're not on anticoagulation. They're not known to have AFib. And we have to figure out what to do with that data. For several years, myself and most of our EP group here were using the 6-minute cutoff. And if people had episodes of AFib that were more than 6 minutes, if they had an increased CHADS2 VASC score, we'd have them come in and talk about anticoagulation or talk to their primary cardiologist or make some kind of clinical decision. That threshold has now moved out much longer. We're not anticoagulating as much for episodes that are only lasting a short duration. Generally speaking, anything over 24 hours or so, we're anticoagulating. Episodes that are in between 12, 18, 24 hours is still a bit of a gray area. I put this slide together to summarize some of the data, but there does seem to be a gradient of risk as a function of duration. If you look at people who don't have any subclinical AFib, there was a study called the Rate Registry that looked at people who had very, very short episodes lasting only 30 minutes, a minute, 2 minutes, that kind of thing, from pacemakers and defibrillators. And at least in the Rate Registry, there was not any increased risk of stroke associated with those really short episodes. A number of other studies have looked at different cut points, 1 hour, 5 to 6 hours, all the way up to more than 24 hours. And as the episodes of AFib start to last longer than 24 hours, the risk of having stroke or systemic embolism seems to be similar to the risk if you have clinical AFib. And along the way there seems to be some background gradient of risk. Now, where in there, what's the clean cut point at which you should anticoagulate somebody? Is it 6 hours? Is it 12 hours? Is it 24 hours? We don't know, and there's a lot of heterogeneity even among our EP group. But suffice it to say, very short episodes lasting a few minutes, 30 minutes, less than an hour or so, we tend not to anticoagulate. Anything over 24 hours, we generally recommend anticoagulation, and then it's a judgment call in between. The one other wrinkle that makes this difficult is that there's also data more recently that suggests that it may not necessarily actually be the duration of any individual episode, but actually the cumulative burden of AFib that's the stronger marker of stroke risk, which kind of makes sense, right? If you have a bunch of very short episodes, an hour or two here, an hour or two there, an hour or two there, but cumulatively the amount of time that you spend in AFib is higher, that might portend a higher risk of stroke than having just a single episode that went on for 24 hours, but all the rest of the time you're in sinus rhythm. There is some data from the KP Rhythm study published just last year that showed that the risk of stroke did seem to increase as the burden of AFib increased into the double-digit range. And these investigators actually went back and compared the duration of the longest episode to the overall burden. And burden seems to be a much stronger predictor of stroke than the duration of the single longest episode. I think over time, we're probably going to move more to using burden than we are single longest episode. But again, what burden, 2%, 5%, 10%, is sufficient to justify anticoagulation remains very unclear. The other thing that is hard about this is that all of our data on anticoagulation really comes from people who had subclinical, or people who had clinical atrial fibrillation, not the kinds of AFib that were detected from continuous rhythm monitoring, but all of the original anticoagulant studies, warfarin and the novel anticoagulants, were done with people who had clinical AFib. And several studies have looked at whether the risk of stroke with clinical AFib is the same as it is with subclinical AFib. And the risk of stroke seems to be lower with subclinical AFib than it is with clinical AFib, even if you control for CHADS2, VASC, or other risk factors. Now, whether this distinction is a function of burden, whether it's just that people who have clinical AFib have a higher burden, or whether there's something else about the pathophysiology of stroke in subclinical AFib that we don't understand, but across the board, subclinical AFib seems to portend a lower risk of stroke than clinical AFib. Now, the problem with that is that obviously, if you're going to make the decision to anticoagulate anybody, the decision to anticoagulate is a balance between competing risks, right? There's the risk of reducing, there's the benefit of preventing stroke, but you also run the risk of increasing bleeding. And so you only want to anticoagulate somebody if their risk reduction from stroke outweighs the increased risk of bleeding. And if you look at a number of the original anticoagulation studies, I took this example from RELY, which was the Bigatran study, but we know that your risk of stroke goes up as a function of CHADS-2 score. Interestingly, the risk of bleeding also goes up as a function of CHADS-2 score, because people with higher CHADS-2 scores tend to be older and they've got more comorbidities, and they're at risk of both stroke and at risk of bleeding. But on balance, we know that as your CHADS-2 score gets over about 2 or so, the net benefit seems to favor anticoagulation. So for most people, on balance, with clinical AFib and a CHADS-2 of over 2, anticoagulation seems to be beneficial. But if the risk of stroke is reduced for subclinical AFib, does that net clinical benefit still have an inflection point at a CHADS-2 score of 2 or not? Or does your CHADS-2 score need to be higher in order to have a net clinical benefit from anticoagulation for subclinical AFib compared to clinical AFib? This is an important question. I don't think anybody knows the answer to this. So all of our management decisions currently are based on data for clinical atrial fibrillation, but whether or not that's appropriate or not, I don't know. Most folks, myself included, use some kind of overall paradigm like this. This is confusing, but it's the best that we've got right now. But if you look at an individual's risk of stroke as a function of either CHADS-2 or CHADS-2 VASC, the higher their risk of stroke, the more aggressive we are about anticoagulating, even for episodes of AFib that are lasting just, say, 6 hours, 12 hours. For people who are at relatively lower risk of stroke, we'll wait until their episodes get to be more than 24 hours before making a recommendation to anticoagulate. So the decision to anticoagulate integrates not only the burden or the duration, but also the background stroke risk. This is hard, though, because it doesn't give you a nice clean cut point which says if CHADS-2 VASC greater than 2 and AFib, anticoagulate. And until we have more data, I think we're going to have to make some kind of patient-specific determination on a case-by-case basis using this kind of paradigm. In the last couple minutes, I just want to finish up talking about some of the pitfalls of screening. For everything that we've talked about so far, and this is a meta-analysis published in JAMA last year, the part that at the bottom here I think is the most important. There has not to date been a single study that has evaluated the benefit of anticoagulation for subclinical atrial fibrillation. As I said, all of the data that we have extrapolates from clinical AFib. And the risk-benefit ratio, I think, is likely to be very different for the kinds of AFib that are picked up from continuous rhythm monitoring, from watches and things like that, as opposed to clinical episodes of atrial fibrillation. We've already talked about this. Apologize, I'm not sure why that box is in the wrong place. But one of the problems that we run into in the clinic is that there's pretty high rates of non-diagnostic data with these devices, right? If the watch doesn't have good contact, if you don't get a clean ECG recording, in that study of hospitalized patients that we looked at, there was about a 20% rate of non-diagnostic data. This is a study that looked at people who were coming into the hospital for cardioversions. And before the cardioversion, they screened them with a watch and they were all in AFib. And after the cardioversion, screened them again with the watch and they should have all been in sinus rhythm. And only about 2/3 had interpretable data segments from the watch, even in this very controlled setting. And these are people in the hospital sitting in the cardioversion suite. These are not people out and about at the grocery store wearing their watch, where the risk of non-diagnostic data I think is going to be much higher. And what to do with these non-diagnostic data segments, how much confirmatory testing is necessary is very unclear. One of the other big problems with this whole field of screening is that the whole field of screening is based on the idea that you have subclinical episodes of AFib. Those increase your risk of developing thrombus in the left atrial appendage, and that thrombus subsequently embolizes to your brain and causes a stroke. And if that linear relationship is true, then screening for AFib with the idea that you can anticoagulate and intervene upstream makes sense. But the problem is there have been several studies now that have looked at patients who have pacemakers or defibrillators or some kind of continuous rhythm monitoring who then went on to have a subsequent stroke. And you see something very interesting. And all of the studies that have looked at this have shown the same thing. A sizable percentage of these individuals don't have any subclinical AFib in the months leading up to their stroke. many of them are only found to have AFib after they've had the stroke, which doesn't really make any sense from a pathophysiology point of view, at least as we understand it. But it really raises the question of whether AFib is more an epiphenomenon and a marker of an underlying atrial myopathy that leads to a hypercoagulable state, and that maybe the idea of screening for AFib upstream won't necessarily hold, because a lot of these individuals who go on to have strokes are only found to have atrial fibrillation after they've already had their stroke, not before. Why this is remains very unclear, but it's been reproducible across a number of studies. The other thing I want to get back to in terms of the pitfalls, this issue of sensitivity and specificity before we wrap up. Number needed to treat is obviously important. We think about that a lot in any medical intervention, but I think it's particularly true as we start to think about screening individuals who are at relatively low risk of atrial fibrillation. If you assume that you screen a bunch of individuals where the background prevalence of AFib is only about 0.5%, which would be pretty similar to the Apple Heart data for individuals in their 40s and 50s who are otherwise pretty healthy. So if you take the Apple Watch crew who had a background prevalence of AFib of about 0.5%, that means you'd need to screen 200 people to identify one new case of atrial fibrillation. Now, if we assume that the absolute risk reduction from anticoagulation for stroke prevention, the absolute risk reduction is about 2%, which is true for most people who have a CHADS2 VASC of 1 or 2, then that means you'd need to anticoagulate 50 people to prevent one stroke. So if you got to screen 200 people to find one case of AFib and then anticoagulate 50 people to prevent one stroke, that means you've got to screen 10,000 individuals of the Apple Heart study variety in order to prevent one stroke. So we're talking about screening massive numbers of individuals to prevent one stroke. And whether at a societal level that makes any sense or not, I think is very unclear. I suspect you can probably tell where my bias lies. The problem is that if you're screening a lot of people, false positives start to become a big issue also, right? If you assume that an Apple device or whatever screening modality you want has a specificity of 95%, which is pretty good. It's hard to get much better than about 95% or so. And you screen a million people wearing Apple Watches, and the true prevalence of AFib is 2% in that population, then that means out of that million people, about 20,000 are going to have AFib. 980,000 won't. But if you screen the 980,000 who don't have AFib with a watch that's got a specificity of 95%, that means you're going to identify 49,000 people just as a function of false positives with a specificity of 95% with atrial fibrillation who don't actually have it. So a large number of individuals are going to get labeled as having AFib, potentially subject to inappropriate anticoagulation if you start to screen populations that have very low background prevalence, because the likelihood of a false positive is so much higher than the likelihood of a true positive. This is some data that'll come as no surprise to anybody, but a number of studies have looked at people who get inappropriately labeled as having atrial fibrillation from false positives, and about 10% of those individuals end up inappropriately treated with anticoagulation, and the incidence of downstream diagnostic testing, echocardiograms, cardiology consultation, whatever, is also pretty high. So I think the risk of these false positives is really substantial when you start to look at it from the overall healthcare system. There are a number of other challenges to this paradigm, right? The idea of screening individuals with these devices that you can buy yourself without needing a prescription or any kind of doctor's recommendation kind of flips the traditional healthcare paradigm on its head, right? Most of the time, we order diagnostic testing in response to a symptom or a clinical concern. Here you have individuals who don't have any symptoms that are, in essence, have a medical diagnostic test performed, and then they come to us with the data and we've got to figure out what to do with it. One of the big challenges for us, and we see this in the EP clinic all the time, is people will come in and say, my device detected or suggested that I might have AFib. They're in sinus rhythm. When you see them in the office, how much confirmatory testing do you have them do? Do you have them wear a 30-day event monitor? Do you put an implantable link monitor in everybody? How much work needs to be done to confirm whether or not this individual had 6 minutes of AFib 3 months ago? Nobody knows the answer to that. How we store this data in terms of our electronic health records, if somebody emails us a PDF of their Kardia band or whatever, which happens all the time, we don't really have a good mechanism right now in our system for storing that data. There's obviously a lot of questions about reimbursement for time and spent dealing with these virtual visits. And then there are medical legal questions, right? If somebody's device says that they might have had AFib, you have them wear a 30-day event monitor, there's nothing there, you make the decision not to anticoagulate them, and then 6 months later they have a stroke. What's the liability for the physician? As far as I'm aware of, there haven't been any cases specifically of this regard, but I suspect we'll start to see them relatively soon. The companies that make these devices are well aware of these individuals. This is an example from the AliveCor website that makes the Kardia band, but they actually have a website and a portal that will interface with your electronic health system, Cerner, Epic, whatever the case may be. And they've got CPT codes that physicians can use to bill to review data from the Kardia mobile devices. And I think most of the companies will end up with some variety of this, and we'll have to figure out how to deal with these things. So last slide, to summarize, there's going to be a lot of data generated. There's a lot of enthusiasm for machine learning algorithms, things like that, to improve the sensitivity and specificity of these devices. I think there probably will be some improvement in the ability to minimize false positives and false negatives. But as we saw already a couple slides ago, the proposition of screening young, healthy individuals for AFib when the background prevalence of AFib is low is going to continue to be problematic, because we're going to run into false positives far more frequently than we are true positives. I'm a little bit more optimistic about what we'll learn over the next few years about the relationship between either duration of subclinical AFib or burden and stroke risk, and where the inflection points lie that suggest that anticoagulation is beneficial. There's a number of studies going on right now that I think will give us much more data in that regard. And Artesia and NOAA AFnet 6 are actually studies that are ongoing and enrolling right now. Artesia is using apixaban. NOAA AFnet 6 is using edoxaban, but they are randomizing people with subclinical AFib, and they're both using the 6-minute cutoff to anticoagulation versus not. And so hopefully we'll start to have some data on whether anticoagulation for subclinical atrial fibrillation is beneficial or not. But until we have that data, I think we're going to be stuck having to make individual patient decisions based on background stroke risk and the burden and duration that any individual has. I think that's it. Thank you.
Well, superb talk. You gave us a lot of information and a lot of things to think about. And I think that's where this technology stands at this time. We'll open it up for any questions that you might have. Thought he did a good job of covering the subject. One thing you didn't mention at all was the loop recorder. And is that, you're just using that to have a more extended period of observation and surveillance?
Yeah, I mean, generally, most of the time we'll start out with some kind of a non-invasive 30-day monitor or something if we're concerned people have AFib. And if we don't catch anything in the 30 days and there's still a lot of risk, somebody's at very high stroke risk or something like that, we'll put in the loop monitor. And these new generations of loop monitors are actually quite easy to put in, and the battery lives are 3-4 years, so you can leave them in for a long time. So for particularly people who you're concerned are having very infrequent symptoms or high stroke risk and they've already had one event, they seem to be helpful. But certainly, I mean, you couldn't use those for confirmatory testing and all these other individuals who are otherwise at low background risk.
Dr. Merchant, great talk. One question. If you're the maker of these devices, what's the answer? Is it just lower your false positive rate?
I don't know. My cynical answer would be do whatever increases your bottom line. I mean, at the end of the day, these are devices that are being marketed to consumers, and there's a huge appetite among consumers to have devices that improve their health in somehow, right? The number of people who come into the office with an Apple Watch that are 100% convinced it's going to prevent them from having a heart attack, which we've all heard, right? I mean, it's hard to get good information, but I think the manufacturers are interested in making the devices better. But even if you develop a perfect widget, if you could get the sensitivity and specificity to 99%, that still doesn't mean that it makes sense to screen the general population, right? I mean, I think at the end of the day, any diagnostic test needs to be applied in a group where it makes sense to do so. And I think many of these, I don't have any firsthand knowledge. I think many of these companies don't view that part of the decision as being their responsibility. Their responsibility is to design a better widget.
Any other questions? Thank you.
Yeah, thank you.